Yes, sir.
Yes.
Yes,
I know
sir.
you're invisible, so it's the best time to, relax in the house and listen to a faculty, a luxury which you will perhaps never have in your lives again. I hope so. So let's start off with the most important part of the topic, that is the epidemiology. And somebody asked me the other day, and I was glad that epidemiology means agent, host, and environment. If there is a question in the exam about epidemiology of filariasis, all of you must remember to write about the agent, the host, and the environment. Now, I'll give you a magic key to this. Host is always the man. Environment in India is always the same. Poor socio-economic status, ignorance, lack of awareness, poverty, malnutrition. These are all the factors which affect the disease, most of the communicable diseases. Of course, the lifestyle has now come to the affluent and the rural both. Rural background, hygiene, sanitation. So what is different in most of the diseases is the agent, right? So you got to know about the agent importantly, and the environment and the host you can always write from your own side, because that's almost the same in all the diseases. Now, agent of tuberculosis, we'll go a little fast because this is a huge chapter, is Mycobacterium tuberculosis, a facultative intracellular parasite, and it is readily ingested by phagocytes resistant to intracellular killing. You know all these things from your micro knowledge. Of importance to man are the human and the bovine strains. Human strain is responsible for the vast majority of cases. Bovine strain affects mainly the cattle and other animals, but it is also useful to us. I'll let you know how. Right? Now, regarding virulence, the Indian tubercle bacillus is said to be less virulent than the European one. Just a thing that you should know and keep it at the back of your mind. In recent years, a number of atypical mycobacteria have been isolated from man. These have been classified into four groups: the photochromogens, the scotochromogens, the non-photochromogens, and the rapid growers. Just for your knowledge, just have this at the back of your mind. Now, source of infection, there are two sources of infection. As I told you, I'll talk a little bit more about the bovine part. Human source, most common. Tubercle bacilli in a human case is usually a mixed group. Some multiply very rapidly, some slowly. More rapidly a bacillary strain multiplies, the more susceptible it is to bactericidal action of chemotherapeutic drugs. Those marked in yellow are the important take-home points. Slow multipliers are the source of persister or dormant bacilli. Just imagine somebody getting affected by a Mycobacterium tuberculosis bacillus, which is a slow multiplier. They can remain alive for years without causing harm to the host, but when conditions are favorable, they may start multiplying again and cause active disease. So the slow multipliers are persisters, they are dormant, and they are dangerous. They are the seeds of future relapse. So that's why, please remember, multiplying very rapidly can be controlled by drugs. Slow multipliers, difficult. Bovine source of infection is usually infected milk, that is from the cow. No definite evidence that bovine tuberculosis is a problem in this country because of the practice of boiling milk before consumption. We also have learned something about pasteurization in the nutrition chapter. So you will know that, if you recall, pasteurization has the effect on these kind of bacillus. Communicability, patients are infective as long as they are untreated. That's why it's very important to catch them, as soon as possible and treat them. Effective antimicrobial treatment reduces infectivity by 90% in 2 days. Host factors, as I told you, it affects all ages. It is mostly seen in developing countries, shows a sharp rise in infection from infancy to adolescence. Therefore, it becomes, if it is a little less prevalent in the infant stage, as the child grows, the prevalence or the incidence rises. In India, from an average of 1% in the under 5 age group, the infection index climbs to about 30% by the time the child is 15. So just imagine the 30-fold jump in the rise of infection among the younger population in India. In the developed countries, the disease is now commonly seen in the elderly. Sex, more prevalent in males than in females. Heredity, no relation with heredity. However, twin studies indicate that inherited susceptibility is an important risk factor. If somebody in your family has had tuberculosis, there are chances. Nutrition. Malnutrition is widely believed to be predisposing to tuberculosis, but the available evidence is indirect. Immunity. Man has no inherited immunity against tuberculosis, and acquired as a result of natural infection or something very important and an exam question, the BCG vaccination. Okay, social factors, there's nothing new. I already told you about them. The poor quality of life, poor housing, overcrowding, population, booming population, undernutrition, lack of education, large families, early marriages, lack of awareness, ignorance, illiteracy, all cause all sorts of illnesses. Why tuberculosis? All these factors are interrelated and contribute to the occurrence and spread of TB. In fact, TB began to decline in the Western world long before the advent of chemotherapeutic drugs. Please underline that. So, this disease is basically attributed to improvements in quality of life. That's why the first line, it's a social disease. Remember, before the advent of the first line, second line, and the other drugs, the chemotherapeutic drugs against tuberculosis, the Western world had won the war against tuberculosis. Mode of transmission, well, we are much aware and we are often using this word nowadays, droplet. TB is transmitted mainly by droplet infection and droplet nuclei generated by sputum positive patients with tuberculosis. To transmit the infection, the particles must be fresh enough to carry the viable organism. Remember, any bacteria or virus, even the new coronavirus, they have a certain life span outside, right? That's why we talk in plastic 72 hours, on a glass, maybe, I don't know, 48 hours. So therefore, it is supposed to be viable when it is put in a droplet by the patient. The coughing generates the largest number of droplets of all sizes. Therefore, cough hygiene or a sneeze hygiene, that we should have a handkerchief or a mask or put our hand and elbow in front of our mouth when we sneeze or cough is very important. Mode of transmission, frequency and vigor of cough and the ventilation of the environment influence transmission of infection. You must open your doors and windows even in the new COVID scenario and let the fresh air come in. They say if you stay in AC for a long time, the virus circulates inside the room and doesn't go out. TB is not transmitted by fomites such as dishes and other articles of the patients. Sterilization of these articles, that is cleaning, as we are talking in the present scenario, is of little or no importance. Patients with extrapulmonary tuberculosis, remember we talked about EPTB or smear negative tuberculosis, constitute a minimum hazard for transmission of infection. Therefore, an active case is the most important factor in the transmission process. Incubation period, time from receipt of infection to the development of a positive TST or tuberculin sensitivity test ranges between 3 to 6 weeks, and thereafter the development of disease depends upon the closeness of contact with the patient, extent of the disease, that is how bad it is in the patient, and sputum positivity of the source case. That all these things constitute the dose of infection and the host parasite relationship. Please remember, 3 to 6 weeks from the receipt of infection to the development of a positive tuberculin test. Thus, the IP may be weeks, it can be months, it can be years. So there's nothing certain in case of tuberculosis. The clinical features, I won't deal with them much because all of you are aware, are loss of weight, fever with an evening rise, loss of appetite, cough and chest pain, hemoptysis, meningitis is a complication, right? There are so many complications. TB can infect any part of the body. One of them, and the most dangerous thing, is the meningitis. The control of TB is what is the heart of this chapter. How do we control this deadly disease? The reduction in incidence and prevalence. There are two aspects, incidence and prevalence. They are both the aim of the National Tuberculosis Program as we know it nowadays as. Anybody aware what is the new name for RNTCP? Anybody in the class is aware? What is the new name for RNTCP? Please find out. In case you're not aware, the question may not come to you as RNTCP, it may come as something else because the program has been renamed. Now, there are two things, curative and preventive. Preventive,
NTEP.
yes,
NTEP, National Tuberculosis Elimination Program.
super. Who's this? What's your
Dimple, sir.
name?
Dimple, sir.
Dimple, very nice. I'm sure the whole class now knows that there's a new name. I thought you will take some time to find out and tell me in the next class, but that was good. Please remember these things. These are small things that are asked in the Viva, and in case you are answering properly, our impression about you is increasing manifold. So, curative, there are two aspects, case finding and treatment. What we are doing in the present COVID scenario is also finding the contacts. Through them, the secondary contacts, primary contacts, secondary contacts, these are words that you are now listening to and they have become very common. Clusters, these have become very common. So we are supposed to do case finding in tuberculosis and treat them. This combination of case finding and treatment is the most powerful combination in the control of tuberculosis. It is not, I'll repeat in capital letters, it is not BCG, which me and you took as a child, right? So therefore, remember, in the control of tuberculosis, case finding and treatment, they are both marked in different colors, is the most powerful combination. Now we'll deal with these one by one. Case finding, what's a case? We all know. Early detection of sputum positives is an intensive and ongoing program. We got to identify the sputum positives. Who's the target group? Majority have one or more chest symptoms. So anybody coming in the OPD, you going to the community and finding out somebody with a chest symptom. So therefore, you have a suspicion of tuberculosis. Majority have one or more chest symptoms early. 60% only seek medical advice on their own. Your role lies in that 40% when you are a public health person. You are supposed to actively seek them out and help them get a diagnosis and in case positive, get a proper treatment. So therefore, we got to target a group. Most of these have one or more chest symptoms, right? Intensified case finding activity or ICF is the third thing in case finding, okay? It is detecting cases early by active case finding and initiating treatment. The TRT is an abbreviation for treatment, promptly screening the valuable population, and we should have a lot of resources available with us for this active, intensified case finding. Manpower, money, because we got to go somewhere and do the screening tests in the form of either, a chest x-ray or sputum test or whatever you want to do. So therefore, intensified case finding activity, right? So we have discussed the case, we have discussed whom to target, and we've discussed active case finding also. We are still in case finding. Now, what are the screening strategies? We just talked about screening. Community, we have a mobile or a fixed facility. So when we go as a SPM person to the community, we have a mobile facility, say a van moving around, or a fixed facility, say a PHC, a primary health center. And we have contacts with symptoms, right? So in the institute, when the patients come to us in the healthcare facilities, it is easier, okay, to screen them. We have got all the investigations available in the labs. Where else do we screen the patients? In institutes like shelters, old age homes, orphanages, refugee camps, correctional facilities, that is juvenile delinquency homes and other like that, and in workplaces. People work in very, very overcrowded scenarios. If you have been to Bangladesh or if you have seen some scenes right now which are coming on TV, in spite of coronavirus, their garment factories are working 24/7. Okay, people are crowded into rooms and then they are stitching clothes for the Western countries or doing something. So therefore, such workplaces can also transmit the bacteria. Case finding tools that you have in your hand are sputum exam, sputum culture, radiology, Mycobacterium tuberculosis from clinical samples, serology. Therefore, that's the fourth thing that you have. The case, the target group, the intensified case finding activity by screening. And what are the screening methods? Where do we do the screening? In the community or in institutes. Now, institutes don't mean hospitals or health centers only. They also mean shelters, old age homes, refugee camps, and the like. And what are the tools that you have? The tools that you have are basically the investigations. So we will discuss the investigations, which is also very, very important for you all to know, especially the first one. Sputum examination. Often a very, very favorite question of the examiners will be asked to you either in medicine or in pulmonology or in pediatrics and of course in community medicine. By direct microscopy is the method of choice. It's the number one tool for finding active cases. Underline that. 2 samples are taken on the spot, that is under supervision. You tell the person, go to the lab. In the lab, there's a trained lab assistant who demonstrates or who tells him how to bring out the sputum. That is on the spot and early morning. Once you demonstrate to a patient, an illiterate patient, somebody who is unaware, then he can bring out the early morning in the house much easier, right? But in case, as a doctor, as a healthcare provider, you find that the patient will not be able to come back tomorrow morning with another, kind of a sample, please take 2 on-the-spot samples. So therefore, the terminology, spot, early morning, spot, right? So there are 2 samples which are taken by the doctor or by the healthcare worker, and we all know that once we prepare the slides, we use zeolite acid fastane, and both the slides got to be examined and a record kept in a register. There can be false positive and false negative, that is with any test. But remember, the first slide comes positive, you can throw away the next slide, no. You got to check both the samples which you have taken from the patient. Small things, but please remember, Zee-Linson technique is something which I can skip, I think, and you all know how to do it. It's a part of your previous MBBS. This is the way the slides are reported. 1 positive slide is enough to declare the patient as smear positive, but yet please examine both the slides and keep a record. And this is the way the lab assistant or the person in the lab diagnoses or says or talks about the result. 0 means no AFB in 100 oil immersion field. 1 to 9 AFB is scanty. It can be this way, that way. 10 to 99, 1 plus. Okay? 1 to 10 AFB per oil immersion field. It is not per 100. It's plus. And more than 10 is plus, and plus. That is 3 plus. We have the other methods also, which are advanced methods like fluorescence microscopy. These are basically used in industrialized or developed countries. They use an Oramin stain. It's speedy, 1 to 2 minutes. The whole length of the smear can be seen, unlike a direct microscopy where we take time. And therefore, the fields are obviously 5 to 10 times bigger. We also have LED fluorescence microscopy, the diagnostic accuracy comparable with fluorescence microscopy. LED gives you the light. LED is because of the light that is being used. So remember, in sputum examination, we can use a normal microscope that you have seen during your MBBS or during your practicals, and we can also use the sophisticated microscopes, that is fluorescence and LED fluorescence. Radiography, we are all aware, useful in smear negative cases and in children because they cannot bring out the sputum. Pleural and pericardial effusion in early stages, when clinical signs are minimal, they can detect, the X-ray chest can detect. Hemoptysis and miliary tuberculosis are also diagnosed through radiography. It is, of course, comes second to sputum. Sputum culture, cornerstone of definitive diagnosis. Once you are suspecting a patient of tuberculosis, perhaps if the sputum, the slides are negative, you can go for a culture. And then there are various, culture media like Lowenstein Jensen, Middlebrook, Krishna's or Middlebrook 7H9 broth. So these are the various, media that we use. There are also some rapid methods like microcolonnade detection on solid media, septic check AFP method, microscopic observation of in-broth Culture. Okay, it is MOBS and not MODS. That's a typo, MOBS. Okay, so there are various modern, rapid methods. There are the previous conventional methods of sputum culture, backtech radiometric 460 system, backtech MGIT 960 system, MB oblique BACT system, and ESP2 culture system. Just remember these names in case you are doing well in the Viva, and in case you have gone through the Lowenstein-Jensen and come down to Kirshner's, we may ask you what are the modern rapid methods of culture of the tuberculous bacillus. And these are the various names. They are given in the book in the form of a bold letter with some description. I'm sure you will not have the time to go through the description because that's not required also in SPM. What is required is the control, and that we are discussing right now. We are still in the cases, by the way. Detection of Mycobacterium tuberculosis directly from clinical samples. This is an alternative for smear microscopy. And remember, we are using a word very often nowadays in case of COVID, which is called as PCR, right? So there are genotypic and phenotypic methods of detection of Mycobacterium tuberculosis directly from clinical samples. And the genotypic method, one of the genotypic methods is PCR. Amplified DNA is visualized in PCR, transcription mediated amplification, and nucleic acid amplification. I should have underlined the nucleic acid amplification because that is what the national program is using now, and it is called as CBNAT. So therefore, remember the word NAA stands for nucleic acid amplification, right? It's a genotyping method of detection of MTB directly from the clinical samples. Therefore, we have cartridge-based NAA test or CBNAT. You will hear this word more often as we go through the chapter. This is the current gold standard of diagnosis of tuberculosis in the national program. We also have genotypic tests like Gene Expert, MTB, oblique, RIF. Don't worry about the details of these things. Just remember, out of all these things, CBNAT is more important. Phenotypic tests we have fast plaque tuberculosis, TB. We also have transcription mediated TMA or nucleic acid. Sorry, this is a repeat. We have just said this, so it's a repeat. CBNAT and gene. I already told you about that. Now we come to serology, useful for screening, low turnaround time, and high NPP. Limited use in high endemic countries like ours. Serology is not of importance in highly endemic nations like ours. It requires expertise, and there is a difficulty in distinguishing between Mycobacterium tuberculosis and non-tuberculous mycobacteria. TB stat pack is another test that is mentioned in the book, immunochromatographic test based on antibody detection, differentiates active and dormant TB. Insta test TB and other antibody tests, namely Mycodot, Detect TB, Pathozyme Myco, Pathozyme TB, impossible for all of you to remember all these things, antigen A60 and ICT diagnostics. Just remember that there are some tests for doing the detection of Mycobacterium tuberculosis directly from clinical samples. They can be genotypic and phenotypic. The most important genotypic test is CBNAT. These are the various things taken from the net, which shows you the backtech test and the PCR and the RFLP and the LRP. Well, we come to something which can come as a part of the long question, or which can come to you as a short note, or which can come to you in the Viva. The most important tuberculin test. It was discovered by von Pirke in 1907. Okay, it is positive when a person has past or present infection with Mycobacterium tuberculosis. Please remember this. Tuberculin test is positive in me and you also, because all of us have the bacilli inside us. It doesn't manifest because of our immunity. So therefore, it shows past oblique present infection with Mycobacterium tuberculosis. And the moment I said it is positive in you and me, you can make out the importance. It is the only means to determine prevalence of tuberculosis in a community. Only two tuberculins are accepted by the WHO as standard. Remember, this is a Viva question. PPDS and PPDRT23, right? Purified protein derivative, PPDS and PPDRT23. What we use in India is RT23. 5 tuberculin units of PPDS is equal to 1 tuberculin unit of PPDRT23. In India, PPDRT23 with tween 80 is used. Okay? Tween 80 is a detergent to prevent absorption on glass or plastic. We keep the tuberculin in a glass vial. So the PPD has to be mixed with tween 80, which is a type of detergent that prevents the PPD from getting absorbed into the glass or the plastic vial, the wall of the vial. Okay? And what is the recommended dose? I already showed you. It is 1 tuberculin unit of PPD-RT23. Very important. Tuberculin sensitivity test, very important. What is the procedure? Look at the diagram. How the expert chap wearing gloves has created a kind of elevation by giving the PPD nicely in the forehand, right? A standard dose consists of an intradermal, right? Remember this intradermal, a 0.1 ml of solution for injection in the inner surface of the forearm, generally the left. And the test is read 48 to 72 hours later. We just create a kind of wheel by giving it intradermally, and we leave it like that. Tell the patient that please come back after 3 days or after 2 days, depending, okay, on you, and then we will do the reading. What happens is a pale wheel of the skin is produced like in this diagram. Slowly we have an erythema and induration. What we measure after 48 or 72 hours is the induration, not the erythema, the induration, right? Remember this will be asked to you. Induration is measured with a scale or calipers. We use a scale, right? If it is less than 6 millimeters, if the induration is less than 6 millimeters, it is considered as negative tuberculin test, or the other name for this is Mantoux test. When we do the tuberculin test, it is called as a Mantoux test. We use a tuberculin syringe. As I mentioned here, we use a tuberculin syringe, the needle bevel facing upwards, and we slowly introduce the PPD-RT23 intradermally. 6 to 9 millimeters is doubtful test. More than 10 is a positive Mantoux or tuberculin sensitivity test. Very important. Please remember this. Less than, more than 5 millimeters, this is the classification of positive skin test. See, we said that 6 to 9 is doubtful, but it is not negative, right? I don't know why the book says 6, but the table gives it as 5. Please remember, it is more than or equal to 5 in HIV positives, in recent contact with an active TB patient, perhaps a caregiver or a healthcare worker, nodular or fibrotic changes on chest X-ray, and in organ transplant patients. Negative test can't be relied upon to exclude tuberculosis. So therefore, the importance of Mantoux test is only to note the prevalence in the community, and just a test which doctors order in case you have, just to see whether you have tuberculous bacillus inside you. I mean, it doesn't give you a diagnosis like you are an active case or you are a sputum positive case. Okay? If it is more than 10 millimeters in the measurement of the induration, as is shown in the diagram, we have got the various, interpretations. And if it is more than 15 millimeters, we know that the person has no known risk factors for tuberculosis. Okay, so this is the table given in your book. Don't dwell too much on this. Just remember less than 6, 6 to 9, and 10, and how the test is done and with what it is done and what we measure. What is the reaction, erythema, and induration? What we measure is the induration, and we can't obviously measure the erythema. There's a 2-step testing also, basically for me and you, and for people who work in close contact with tuberculosis patients, that is healthcare workers. Some previously infected persons may have a negative reaction when tested years later. I may have tested positive 10 years back because I was in a TB ward, posted there, working in a pulmonology department. But now I have tested negative. Okay? Because my immune response has gradually died down. Initial test may boost the body's ability to react to tuberculin in future tests. So what we do is we do the tuberculin testing twice. That is what is called as two-step tuberculin testing. Please remember, generally when we do the tuberculin test, we do it only once, as I discussed before. But we can also have a two-step testing for the healthcare workers who were maybe after years of being tested positive, they tested negative. So therefore, we do the initial test and then we do a second test after the initial, which is called as two-step testing in case the first test is negative, right? So just remember something called as two-step testing. This is what is the two-step testing in a diagrammatic or a algorithmic form. Again, 10 millimeters is the benchmark. If it is less than 10, person probably does not have TB infection. If it is positive more than 10, this is a boosted reaction due to TB infection long time ago because he was exposed to a patient with tuberculosis, or he himself had, or perhaps he worked in an environment where there was likelihood of him getting the bacillus. So we come down, we have discussed about the cases. In case you remember, we have talked about a target group. We have defined a case, that's a sputum positive case. We have discussed about the active screening and the screening methods, the screening places, that is the community or the healthcare settings or other institutions. We have talked about the tools available with you, the most important being sputum, test. And then we have also important tests like CBNAT, which is the gold standard. We have talked about sputum culture. We have talked about directly getting the Mycobacterium tuberculosis from clinical samples. We have talked of chest X-ray, and we have talked about various media, which we have the traditional media and the rapidly growing in the media where the bacillus rapidly grows. So we come down to one of the most important parts of this chapter, which is chemotherapy. One of the most significant advances of 20th century has been chemotherapy of tuberculosis. It is indicated in every case of active TB. Elimination of fast and slow multiplying. Please remember, we started off with fast and slow multiplying bacilli, including persisters is the A. The effect is measured by elimination of bacillus from the sputum. It is available free of cost by the government. That's why somebody said NTEP. Applied to entire pool. Patient compliance is a very important factor because for anything, I give you the medicine and I expect you to take it. In case you don't take it and bring me the foil saying that I have taken it, but whereas you put the drug in the drain, then I've got nothing else to do. You're not compliant. I've got no means to really find out or prove that you are guilty of not taking. Incomplete treatment results in relapse, resistance, and community is put at risk. Imagine, I don't take the treatment of TB fully, I do it incompletely, I put all people around me at risk, including myself, for a relapse, and of course, development of resistance with which we are still fighting. There are 12 to 13 drugs now, of which 6 are essential, right? And they are either bactericidal or bacteriostatic. According to clinical utility, the anti-TB drugs can be divided into 2 groups. Please remember this, first line and second line. First line, high anti-tubercular efficacy as well as low toxicity. And the drugs are the most commonly used: isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. Please remember the abbreviations are in the form of capital letters in brackets. Isoniazid S, H, rifampicin is R, pyrazinamide is Z, ethambutol is E, and streptomycin is S. Second line drugs have low anti-tubercular efficacy and high toxicity. These are namely PAS or para-aminosalicylic acid, cycloserine, kanamycin, amikacin, ciproflox, ofloxacin, clarithromycin, and azithromycin. We will talk more about the second line also. These are the first line drugs. This table has been taken from your book. Remember, the drugs have a mechanism of action, like with Red and Pharmac. There is a route of administration. If you see, except for streptomycin, all are oral. Streptomycin is injectable, iron, right? And they all are bactericidal, except ethambutol, which is bacteriostatic. Remember this, right? There are some side effects which you got to know because they are again a part of your viva question. You got to tell the patient, in case he is taking a certain drug, that he may land up with a reddish orange discoloration of his urine. He may get a shock, but since he is using the drug R, rifampicin, therefore you have to tell him about the side effect. Well, ethambutol has the important side effect of retrobulbar neuritis. Pyrazinamide is hepatotoxic, and streptomycin, we all know, is ototoxic, vestibulotoxic, cochleotoxic, nephrotoxic, right? So the red ones, other than the one in isoniazide, they denote a serious drug reaction. And in case the patient reports to you with hepatotoxicity due to rifampicin, the book says you should not give the drug again. In case he has retrobulbar neuritis, do not give the drug again. We have to replace it. So these are the first line drugs, right? INH, rifampicin, ethambutol, pyrazinamide, streptomycin. The second line drugs are fluoroquinolones, aminoglycosides, ethionamide, capreomycin, cycloserine, thioacetazone, macrolides, bedaquiline, which is a fairly new drug, and delamanid, right? The last two are the newest. And remember the side effects of each of these. Well, we are a little lucky. Though we said that the second lines are more toxic, we have only got to worry much more about thioacetazone than the others, because that gives rise to GI disturbances, blurring of vision, hemolytic anemia, urticaria, and agranulocytosis, right? In the first line, almost all the drugs are toxic, though the toxicity is low, and therefore the incidence of toxicity is rather low. But in case the patient reports with a side effect, please remember to replace the drug. In the second line drugs, thioacetazone causes agranulocytosis, and therefore one should be careful with it. Well, the grouping of anti-TB drugs has been done as per the WHO guidelines, and we have got the various drugs in the categories as A, B, C, and D. See, all these are given as tables in your book. They are not very, very important, and they are also impossible to remember. But since they are given, we should know that there is a table like this, and when we go back to the book and read, not get confused, but just have a look at the table and remember that in the class also the same table was shown to you, right? So there is something called as a two-phase chemotherapy in tuberculosis. We all know there is an intensive phase, which is short, aggressive, 3 or more drugs are used, and this is for killing off as many bacteria as possible. Remember, the war is won perhaps on the first day. The boxing bout is won perhaps with the first punch that you give, because in case that is lethal, the opponent can't get up. You've knocked him out, right? So intensive phase is to knock out the maximum bacteria as much as possible. So therefore it is short, it is aggressive, and there are 3 or more powerful drugs being used, first liners, and the risk of relapse and persistence is therefore less. In the continuation phase, we just are bothered about the persistence, right? Sterilizing the dormant and persistence. So the second line, we are basically, in the continuation phase, we are basically worried about the persistence. The standard 18-month therapy cut down to 6 to 9 months with the introduction of rifampicin or pyrazinamide to regimens with INH. This was done by Wallace, Fox et al. In 1972. So previous to 1972, we used to have a TB patient go to a sanatorium up the hill and take the treatment for months perhaps. He couldn't afford it. Many people died of tuberculosis. Even now they are dying, but they are much less. And it used to be a 1.5 years treatment. Now this has been cut down to something like 6 to 9 months, okay? So the introduction of rifampicin and pyrazinamide was so important. We have something called as domiciliary or ambulatory treatment. Remember, these are words that can be asked to you in the exam. What is domiciliary? Domestic. What is ambulatory? You are moving around and you are having the drug. Like suppose I go to my house and I have a medicine, I'm ambulatory, right? It's an ambulatory treatment. It's not a hospital inpatient treatment. Self-administration of drugs, generally oral. Obviously, I can't take an injection other than diabetics who take insulin. Okay, so most of the self-administration is oral by patients themselves without recourse to hospitalization. What is domiciliary treatment? It is self-administration of drugs by patients themselves without recourse to hospitalization. Clinical trials at TB Chemotherapy Center, Chennai, showed that incidence in contacts treated at home and at sanatoria or hospitals is the same. So therefore, it's equally good or equally bad. So there's no harm in taking the medicine in the house. So we have something called as domiciliary treatment in most of the cases of tuberculosis. It is cheaper for the patient, cheaper for the healthcare facility. It is managed at the primary healthcare level, right? That is what the government wants. Short course chemotherapy has got a lot of benefits, including the previous one which we discussed. It has got rapid bacteriological conversion, low failure rates, reduction in emergence of drug resistance in case the patient is compliant. Patient compliance is better because he feels at home, and incidence is therefore reduced, and therefore infectiousness of the patient is also lesser. He will infect others lesser. The only deterrent to chemotherapy is high cost because the drugs are costly. But then the government has been nice and we did not bother so much because it is given free of cost. We have something called as DOTS, and I have marked the D, O, T, and S in red because the word DOTS means directly observed treatment short course. It is pathetic when a short note comes in DOTS and most of you cannot write the full form of DOTS. Once you don't write the full form, as an examiner, I don't feel like reading the answer because I know you don't know. Directly observed treatment short course, right? It is observed directly. It's a short course and it's a course of treatment. It provides the most effective Medicare and it confirms to the healthcare worker that the patient has taken the medicine. So initially when they found poor compliance and various other factors, the thing like DOTS came up. It's effective worldwide on a program basis, recommended by the WHO. In the intensive phase, the patient swallows the drug in presence of a healthcare worker or a trained person. You are standing there, the patient is asked like a small child to take the medicine and swallow it in front of you. In the continuation phase, once the patient is trusted, perhaps like we say when the child has grown up, we trust him a little more and leave him in the house for a few hours on his own. The patient is assured medicine for a week in multi-blister combi packs. Okay, multi-blister combi packs. The first dose is taken in front of the healthcare worker. You've come to the TB center or the DOT center. You have been given the combi pack. The first dose you're supposed to take in front of the healthcare worker. He will give you a glass of water, and you're supposed to take the first dose. The rest of the doses you're supposed to go back home and take, and bring back the empty multi-blister pack after a week to take your next 1 week dosage of medication, right? The patient-wise boxes are labeled in DOT center. I'm sure you people have visited a DOT center when you were in third semester, and you've seen patient-wise boxes are there. The person there, he opens up your box and gives you the medicine from that, because in that the dosages are kept for you for the next few months. You finished 1 month, 5 months are left, so it's kept there. Okay, and remember, the patient-wise boxes, the drugs inside them have sufficient shelf life. We'll just take 5 more minutes. Introduction of the daily dose regimen in RNTCP. Somebody said the name has been changed, or rather I said, and somebody also mentioned correctly. Well, now, initially we had DOTS, the patient taking the medication alternate days, right? Now, the RNTCP previously and now the RTEP, they have recommended that there should be a daily dose regimen of the medication. Drug-sensitive TB patients, thrice weekly regimen, that is alternate day, changed to daily fixed dose combination or FDC. For you, you should remember the patient should take the medicine daily. And for mono, poly, multi, or extensively drug-resistant TB, we have got the other regimen, right? I'll talk about the resistance part a little later. Drug-sensitive TB patients, remember we do a drug sensitivity test, which is called as drug sensitivity test in a DST or a center, right? And then you are giving the medication. Drug sensitive TB management came up in 2016. Presumptive TB, case finding strategy, and microscopically confirmed TB are two types of TB cases. One is confirmed by sputum and one is presumptive. You are seeing the symptoms and you are thinking that the patient could be a case of tuberculosis. What we do is pre-treatment counseling and evaluation of the patient and family members. We also check for comorbidities, tobacco and substance abuse. We talk about the socioeconomic status of the family. We do an HIV test. We do a pre-treatment evaluation of the patient, and symptom-based approach for management of common side effects are also instituted. Patient-wise boxes are labeled. Now, this is the algorithm given in your book about pulmonary tuberculosis treatment. It is slightly, here and there, but it's quite easy. Once a presumptive TB patient comes to you, do a smear examination. In case smear examination is not available, do a chest X-ray. You can either get smear positive and chest X-ray positive. You can get smear positive, chest X-ray not positive. You can get smear negative, chest X-ray positive. You can get both as negative, or both are not available, but your clinical suspicion remains high. So what we do is, generally when we are in doubt, we go for a CB-NAT. See, I told you how important is cartridge-based nucleic acid amplification test. And based on that, we detect MTB or we do not detect MTB. See, it is detect MTB or do not detect MTB. And once we detect MTB, we also do a drug sensitivity test to find out whether the person is rifampicin sensitive or is rifampicin resistant, and then we initiate treatment. So what this whole jing bang gives you is that when a patient comes to you, when you are suspecting TB, do a smear examination, that is a sputum smear, and in case you have the sophisticated microscopes, do a LED fluorescent microscopy or a Zeelinson staining, and after that a microscopy. And then in case you also have a chest X-ray or you want to do a chest X-ray, do both, and then you can get 4 types of results. In case you are in doubt, that is, you feel that the patient is PL-HIV, that is person living with HIV, and in case you feel the clinical suspicion is high and both chest X-ray and the sputum, they are not available or not very suggestive, do a CB-NAT, which is a very, very important test nowadays and which is the gold standard, right? Please remember to counsel the family members and the patient each time you call him or each time you initiate a test. So treatment regimen for a case of pulmonary tuberculosis in patient-wise boxes marked as red or blue depending on what type of TB case you are treating. It can be a new case or it can be a previously treated case, right? And the figures in brackets talk about the months. 2 months of HRZE and 4 months of HRE. Now all of you know what is H, what is R, what is Z, and what is E by now. And in case the person is previously treated, you have a blue box for that, blue box containing all the medicines, in which 2 HRZES or streptomycin is added, injectable, plus 1 HRZE. This remains the same. But remember, this is a 6-month therapy and this is an 8-month therapy. With the intensive phase or IP for 2 + 1, 3 months, and continuation phase of 5 months. This table is given in your book, very important table. Please remember this, please mug it up. 2 + 4, HRZE, and then Z gets eliminated, pyrazinamide is taken out, and 4 HRE. Previously treated patients, 2 HRZES, then after 2 months of S, 1 month of HRZE, that is like the new patient, and 5 months, and not 4, of HRE, right? So daily fixed dose combination, no extension of intensive phase is done. If it is 1 month and the patient is not improving, you have to go to the continuation phase. If it is 2 months, and if it is 3 months in case of the previously treated patients, if it is not improving, please go to the continuation phase. Don't extend the intensive phase. Pyrazinamide is stopped in continuation phase. We all discussed that. Streptomycin is stopped after 2 months in intensive phase of previously treated. Same thing I'm repeating. Okay, continuation phase may be extended. Intensive phase is not extended. Depending on the pulmonologist or the physician, continuation phase may be extended by 12 to 24 weeks. That is 3 to 6 months, depending on the physician, in case he feels that the patient has been affected in the central nervous system, skeletal system, has got disseminated tuberculosis, right? But all this has to be done with the consultation of a pulmonologist. Loose drugs for adults weighing less than 25 kgs. In case you have an adult who's weighing less than 25 kg, all of you must have seen a TB patient. Some of them are very, very cachectic. Then we don't have combi packs. We have loose drugs, because the combi packs come with the body weight kind of a dosage. We take the body weight of a patient as 50 kg and then we pack in the drug. In case the adult is weighing less than 25 kgs, all the previously mentioned drugs, they have to be given loose. That is, like we have 4 or 5 tablets, right? And in case he has an adverse reaction or some comorbidity, like we talked about the side effects, they have to be substituted or replaced. Please remember, we have talked about a pulmonary TB case treatment. Next class, we will finish the multi-drug resistant or the drug-resistant tuberculosis treatment, which is a little complicated, a little different than the normal treatment of a pulmonary tuberculosis case who's either a new case or a previously treated case. Previously treated means I've been treated, I've been cured, after years I again get the disease, so I am supposed to now go on for an 8-month therapy. In case I'm a new case, I have to go in for a 6-month therapy, right? This is a fixed dose combination. This is what loose pills look like, and all these pills got into one pill is a fixed dose combination, right? Fixed dose combinations have been recommended by the WHO. The justification, I need not justify, you all must have known by now. It is simple, it improves compliance. Instead of giving me 5 drugs, you're giving me 1. The logistical ease is there. Just give the patient 1 blister pack and he has to take one drug every day. And it prevents multi-drug resistance, right? So therefore, FDCs, they say, will facilitate and support DOTS programs. They are not an alternative. They are here to support the DOTS programs, right? These are the various weight-wise, body weight-wise combinations given in your book of the intensive phase drugs and the continuation phase drugs. Correct? Streptomycin is not there here in HRZE. It is given separately. So this is just the dosage. In case you are doing well, you can write all this. In case you remember, you can write all this. This is how the patient-wise red boxes look like. I talked about 2 colors, red and blue. Okay, so this is how the red boxes look like, and what they contain is all given here. They are fixed dose blister packs. You can see the blister packs here. You're supposed to give 1 per week to the patient. He's got to come back and take the next one from you, and then take the first dose in front of you, which ensures compliance. There is a separate table given in your book for pediatric TB. Could be important for you in pediatrics. We in SPM are not very keen to go into details. It's a body weight kind of a dosage given to you. Please go through it. In case you are doing pediatrics in your next MBBS, you will have to use this. Okay, follow-up of treatment. We obviously follow up all the patients clinically by asking him to come back to you monthly. In case he's on DOTS at home, we check for chest symptoms, we check for weight gain. We also do some lab investigations at the end of intensive and continuation phase, which is given in your book. This is sputum microscopy, and in case we find that the sputum is negative at the end of IP, it's good prognosis. In case the sputum is not negative, that means the prognosis is not good. We do a long-term follow-up at the end of 6, 12, 18, and 24 months. That is at 6 monthly intervals. Here we have monthly intervals of clinical checking, and here we have follow-ups of every 6 months. Okay. This is the CBNAT test being done. Just a photograph. Too much of writing. I thought I'll show you a photograph. And next class, next Wednesday, we will finish TB. We will talk about drug-resistant TB management and a few other points which are left, as well as the BCG vaccination. TB is a very, very important topic. Some of you may have missed the class. If you go through the book, it is slightly confusing. So I'm sure you will ask your friends who attended and the good students, and you will discuss this, as well as open your books of medicine, pediatrics, and try and find out from them and relate it to SPM, and then understand the whole topic. It is quite complicated. It takes us as faculty to understand this, because we are not pulmonologists. We are just teaching you tuberculosis from the SPM point of view. But remember, this is a very important topic, and few questions can come from here. We have discussed the initial part of tuberculosis treatment today. In the end, we have talked about two very important topics in control of tuberculosis, which is case finding and the second one is chemotherapy. Case finding, we have got a lot of tools with us. Importantly, remember the sputum smear test and the CBNAT, right? Remember these words. In chemotherapy, we have got first line and second line drugs. We mentioned both the drugs in form of tables. We have also mentioned some important side effects. We've also told you the dosages of adults and pediatric dosages in case of pulmonary tuberculosis. Next class, that is the third one for this important topic of tuberculosis, we will try and wind up. Okay, and after that we will go on to intestinal infections. Time is short. Instead of 4 classes, we have 3 classes per week. We also have online, so we don't interact with you. We can't even take a slip test till this lockdown opens and you people come back to college. So these are very trying times. We are still making an effort. I hope all of you are making an effort by listening in, making your notes. And as I requested to you each and every time, please open the book after the class, have a look at where the chapter lies, underline a few important things that your faculty has told you, and try and read them sometime in your spare time. You have lots of spare time now. You can't have any excuses. And just remember 1 or 2 important things which are important from the exam point of view. Thank you for a patient listening. See you next week.